Hi, my name is Gabor Libertini. I'm one of the consultant vascular surgeons at the Northampton General Hospital. You are likely to be watching this video because you have had or about to have a discussion about abdominal aortic aneurysm with me or with one of my consultant colleagues. Hopefully this will add to your understanding a little more on this matter. If you have an aneurysm somewhere else other than the lowest part of the aorta, some of what I will be talking about still applies, but details will significantly differ. Please discuss these with your vascular surgeon. The aorta is the largest artery in the body, a pressurized tube taking blood from the heart and distributing it through its branches to organs. This picture shows the course of the aorta from the heart to the level of the umbilicus or belly button. Here it divides into two large branches called the iliac arteries. These are the arteries that go on to supply organs in the pelvis and then the lower limbs with blood. When an artery, including the aorta, swells or dilates to an abnormally large size, we call it an aneurysm. In the aorta, this most commonly occurs at the bottom part. The development of such an aneurysm usually takes years. The older we are, the more common it is, and it is much more common among men than women. There is much we don't know why aortic aneurysms develop in some people, but we know that with bone factors, current or previous history of smoking and high blood pressure have a role. We also know that in people who have aortic aneurysms, atherosclerosis is also very common. This latter leads to other serious problems such as strokes and heart attacks, which are among the commonest causes of death. The vast majority of abdominal aortic aneurysms do not represent an immediate danger to the patient. However, the bigger they get, the more likely it is that they burst or rupture. Imagine an air balloon. The bigger it gets, the more likely it is to pop. This is somewhat similar to how aneurysms behave. A ruptured aneurysm causes a huge internal bleeding, which is often fatal even if treated with an operation at this point. When we diagnose an abdominal aortic aneurysm before it ruptures, we estimate the risk of such a rupture based on the diameter of the aneurysm measured by an ultrasound scan. Normally, the maximum diameter of the abdominal aorta should be less than 2.5 to 3 centimeters or about an inch. The aorta has to swell to about twice this size before the risk of rupture is great enough for us to recommend an operation. There are rare exceptions from this general rule. The reason that we do not recommend repair with an operation for smaller aneurysms is because the operation itself carries some significant risks which have to be weighed against the risk of the aneurysm itself. Many abdominal aortic aneurysms will never reach a size during the patient's lifetime that requires repair. If the patient has a small abdominal aortic aneurysm, i.e. less than about 5.5 centimeters in diameter, we will most likely recommend regular ultrasound scans to keep an eye on its size. We will also recommend medical treatment to slow down the progression of arterial disease. These simple but very important measures include adequate treatment for high blood pressure, treatment for diabetes, lowering cholesterol levels with simvastatin or a similar drug, taking aspirin or another, as we call it, antiplatelet agent, and of course, very importantly, stopping smoking. If the patient's aneurysm is at a size where we consider an operation to repair it, we organize a number of investigations in preparation for this. We will arrange a CT scan so we can assess the exact anatomy of the aneurysm and plan treatment. We will also organize other investigations to assess each patient's general health and individual risk. We will also discuss each patient with an anesthetist specializing in anesthetizing patients with vascular problems and perhaps other specialists such as cardiologists. The general principle of an abdominal aortic aneurysm repair is that we relieve the pressure the blood exerts on the weakened aneurysm wall. We do this by leading the blood flow through a stronger artificial plastic tube. We can achieve this in one of two ways. In an open aneurysm repair, we make an up and down or side-to-side cut on the abdominal wall. Then we find the aorta above and the iliac arteries below. We put metal clamps across them so they don't bleed and suture the artificial tube or graft in. With the endovascular repair or EVAR, We make 2 small cuts in the groin, and with the help of various wires and X-ray equipment, we push the plastic tubes, in this case called stent grafts, in place inside the aneurysm so to exclude it from blood flow. This first picture shows the principle, the second shows what it looks like on a 3D CT reconstruction. If you wish, you can find more realistic images or even videos on the internet or YouTube. Not all abdominal aortic aneurysms are suitable for EVAR. Both endovascular and open approaches have relative benefits and disadvantages compared to each other. This is discussed with the patient in outpatients. As I previously mentioned, abdominal aortic aneurysm repair with either approach may have significant complications, including a small risk of death. The operation puts burden on the heart and may lead to a heart attack. Many of the investigations we carry out beforehand are to assess and reduce this risk. Another potential complication is bleeding. There is a small risk. We have to take the patient back to the operating theatre to control it. Most of the rest of the complications are related to the fact that the aorta supplies blood to many important organs and also to the lower limbs. This blood supply can be inadvertently compromised during the operation. This may result in serious problems in organs such as the kidneys, parts of the bowel, the legs, rarely the spine. In outpatients, we discuss these potential complications with each patient. Putting this the other way around, whilst abdominal aortic aneurysm repair is undoubtedly a major operation, can have complications and will on average take 2-3 months to recuperate from, it is also a routine operation and most patients do very well. If you are a patient and want some further details, please ring the Northamptonshire Vascular Service on 01604 545580 or ask for your consultant secretary through the Northampton General Hospital switchboard on 01604 634 700 and your consultant will ring you back.